Hello everyone, we're going to go ahead and get started. It's 12:30 and we've got a lot of information to pass along. Thank you all for joining us for today's Lunch and Learn webinar. There's no video component for this session, so if you see a little video box pop up, you can X out of that. We had some WebEx link issues this morning, so I had to resend out one. So if it's not working appropriately, you can always text me or call me, and my number will be up here in just a second. This category or this presentation does qualify for Category 1 AMA PRA credit, whether it's live or you're listening to this as a recording. There'll be some information at the end of the presentation of how you can claim that credit. For questions during the presentation, we have the phones muted so that we don't hear any background information. So if you do have a question, there's a little box at the top right-hand side of your screen that says chat. If you click on that and you scroll down till you find Alex, you can chat with me, send me your question, and I can ask Dr. Whalen during the presentation, or you can wait. We might unmute the phones halfway through for questions, but we would definitely unmute them at the end for any questions or comments that you have. This is my contact information. My email is up there, my office number. If you're interested in joining our network and you're not on our mailing list, or you have a colleague or peer who you think would benefit from some of our educational sessions or to be on our mailing list or to get our newsletter, any of those things, just let me know and we can get them registered. It's all free. The purpose of it is to connect up local clinicians with local pediatric medicine experts in our area so that we can create a good dialogue and talk about local issues and what local resources we have. So. This is just a reminder of some of the educational sessions we have. I'm trying to go a little faster because I know Dr. Whalen's got a lot of information to cover. So we do Grand Rounds webcasts on Thursday mornings from 7:30 to 8:30. We do these Lunch and Learn webcasts, usually the first Tuesday. This one's the last Tuesday of the month from 12:30 to 1. These are a little more bite-sized. You can find all of our educational material that we are able to record on our YouTube channel. If you just search for Carilion Children's Outreach Education in YouTube, you will see our channel. We've been migrating most of our stuff from our previous Carilion Clinic playlist over to our own Carilion Children's channel. So if you have any questions about that, you can always email us, and we're happy to answer them. Last shameless plug, we do have our pediatric conference coming up on December 1st. Here in Roanoke. This year we're talking about kind of the special needs of children. They all have them, and what are they, and how do we meet them? We've got a great group of speakers. I believe we have 14 presentations going on throughout the day. We've got some great keynotes coming in, and I think we only have about a dozen, maybe 15 spots left out of 275 seats. So they filled up really quick. If you're interested in going, there's still a few seats left, but if you can't get in, let me know, and we can see if we can't work something out. But last shameless plug. Today's presenter is Dr. P.J. Whalen. He is one of our hospitalists here at Roanoke Memorial, and he is going to be talking about the bronchiolitis and RSV season that is almost upon us. So I'm going to switch it over to him, and I'll be standing by for questions if you have any.
Thank you, Alex. And yes, indeed, I am Dr. Whalen, one of the pediatric hospitalists here at Carilion Children's. I do not have any financial disclosures or anything yet in my life, maybe someday. So we're starting to see bronchiolitis cases trickle into the Children's Hospital. It's a good time to review before the bulk of the season is upon us. Friend put together this case. I had a chance to review it, so let's start with a little case. Of course, we're going to start at midnight in the first week of December with a child who should still be in the womb, but at 34 weeks gestation came out, is now 2 weeks old, and mom's chief complaint is that he's turning blue after his feeding. She reports 2 days of cough congestion, and that he's feeding a little bit less, a little bit more fussy, less active. He has vomited once. Pertinent negatives in his REU systems include no fever, normal urine output, no rash, no diarrhea. A little more history. He almost made it to 35 weeks. He was induced for maternal hypertension, gestational diabetes was present, Mom was adequately treated for group B strep. He did have a prolonged rupture of membranes, but was monitored in the NICU for a week prior to going home. Of course, there's family at home, including a sibling with a cold, and no specific family history in this infant. So let's see what this child looks like on arrival to a facility at the middle of the night with a chief complaint of turning blue after a couple days of cough and congestion. So we see the infant is crying and grunting, no fever, a little bit on the high heart rate side, but not impressive for such a small child. Respiratory rate of 62 is maybe up a tiny bit, decent blood pressure for age, and then a pulse oximetry saturation of 89% is obviously a little bit on the low side. Other things, we've got a soft fontanelle, nasal congestion, moist mucous membranes, a little bit tachy, good pulses, and then the meat here, the respiratory exam shows a child that is grunting, tachypnic, with mild subcostal retractions but clear sounds, and nothing else that was deemed pertinent. If you refer to one of our bronchiolitis index scoring systems, we could score this, the 1 is the lowest possible score because you always have a respiratory rate. We're going to try to get a little bit of objective information out of all of these little subjective things. The first one, auscultation, how, are you really that much worse if you're wheezing more? We could argue the strengths and weaknesses of this, but by and large, a lot of places do use these, and the literature is actually full of trying to figure out which ones of these are the best. But for the time being, we've got a scoring system that gives this child a couple points for respiratory rate, a point for retractions, and a couple points for difficulty feeding or agitation, and he would score a 5, which kind of puts him in the middle area. It doesn't by itself raise the alarms that this kid needs any specific therapy, just gives us something to track over time. So nursing staff also reports that the child had a brief cyanotic episode event during triage. Well, I guess by definition it was brief, which means it's not ongoing. So what would you do next in your management? We probably don't need to intubate just yet. We probably don't need a non-rebreather just yet, but hey, if the kid's blue and that's the oxygen you've got, give him some oxygen. Probably not a long-term recipe to stimulate this child every 10 seconds around the clock. We've all got better things to do with our time. So let's put him on some oxygen. In some areas, we do have the ability to do this heated, humidified, high-flow oxygen therapy. Specific devices, specific companies have different products, but basically there's this high-flow system that we are using more and more, and again, it does allow for a little bit of pressure throughout the respiratory cycle. And anecdotally, it's been great. We've used it a tremendous amount in my previous children's hospital and in this children's hospital, in the ICU, more and more in the emergency department, getting kids started on it as well. Studies, here's a couple in 2010 and 12. As I was reviewing things again last night, there's more and more studies suggesting that this is probably a good thing, but it's still not clear scientific. One study was saying it's great and we should start it on the pediatric floor because then the patients go home faster and have a less bill. Another study was suggesting that we should be very careful with it because we had a couple of pneumothoraces with it. So not surprising, the literature is a bit mixed. But anyway, for the little preemie that we were talking about in our case, needs some oxygen. So if you have the ability, he might be a candidate for this. If you don't have the opportunity or the ability to do heated high flow, just humidified oxygen by nasal cannula. Again, enough to get him saturated. 2 liters is probably a good amount for such a tiny little body. Certainly a child that's showing the signs that you've seen there, you probably don't want to give him the extra stress and challenge of putting a bottle in his mouth. He's probably going to be better served with a feeding tube so that you can feed him without all that extra effort or coughing or choking, or, kids with a respiratory rate above 60 will often struggle to suck, swallow, breathe in a coordinated fashion. So certainly think about nasogastric feeds. IV fluids are an option, but again, if you've got a primary respiratory illness, the gut should still work if you can feed it gently and safely. Certainly these kids are responding, and there is actually literature now reminding us that upper airway suction is a good thing, and just upper airway suction, not even deep nasopharyngeal suctioning was not better and did have some complications. So suction these kids, a little bit of saline and upper airway suction. Certainly stimulation is needed for these kids from time to time, but obviously if a child needs stimulation, is having apnea needing stimulation, they clearly need to be cared for in a close monitored environment in the hospital. And then certainly some of these kids can just completely go apneic long enough that they do require more than these non-invasive things. It's certainly possible, especially for our little preemies, to end up intubated. So back to our little 2-week-old preemie, couple of labs that were done. We could talk about how much we thought they were normal or they were needed or not, but his blood sugar, it's always nice to know that that's normal. His white count probably wasn't going to change much if it was high or low or normal. Blood culture, again, this child didn't have fever, so I'm not sure that was absolutely necessary. But if you're worried about a kid from an apnea point of view, you're not convinced that it's all respiratory illness. Certainly, the younger and smaller they are, the more we do with blood and urine. And then an RSV test also. Again, we'll cover that, the necessity of that or not. I'm guessing that this big green circle means that the RSV test, or this big green diagram means the RSV test was positive. Here's a good topic for debate that would take longer than we have. Does this kid, 2-week-old, former almost 35-weeker, who doesn't have a fever, does have apnea, does have respiratory illness, does he need a lumbar puncture or not? Arguably, no. The risk of serious bacterial infection in little febrile kids with respiratory infections, I think is even better way to say this than ours. So when they're RSV positive, the chance in this study was exceedingly low for serious bacterial infection. A lot of people still do check urine in these kiddos because of the possibility of having that comorbid condition at the same time. But again, primarily we're dealing with a respiratory situation, and in this specific case, the child did not yet have fever. So this case did get admitted. He was on nasal cannula oxygen and NG feedings a couple days later, so he's now on day 4 of illness. He was having enough apnea that he was transferred to the pediatric ICU, spent 4 days there on heated high flow. That was gently weaned until he was stable to come back out to the floor, where oxygen was further weaned, feedings were weaned from NG back to oral, and the child safely went home. So not an uncommon scenario. Tough age to get a serious illness, and something that to some extent we're all going to be seeing more or less over the next several months. So I had an opportunity to review and discuss with my ICU doctors the different evidence that has come out since this big clinical practice guideline came from the American Academy of Pediatrics, and not surprisingly, almost nothing has changed. There are no convincing or compelling studies out there to suggest that we should be doing anything different. Different countries, there's there's a lot of different recommendations out there, but these are firm and strong in many ways, and nothing has come out in the past couple of years that would make any of us around here think that we should be doing anything differently. So again, you can find these with any quick search. You don't have to have a membership to anything to find the American Academy of Pediatric Clinical Practice Guidelines. So this one came out in 2014. Like I said, there's a lot of continued support for it. Jumping right into the clinical practice guidelines for bronchiolitis. And again, this is talking about bronchiolitis first time episode in a child of I've already lost my reference. I can't remember if it's the first year of life or not, but we're not talking about older kids who might be asthma. We're not talking about recurrent situations. We're talking about, is this a pure, isolated, young child, first year of life with clinical diagnosis of bronchiolitis? And within that context, there are some very strong guidelines, and again, they are listed with the evidence quality, that's the letter grade, and then the strength of the recommendation. So in the diagnosis of bronchiolitis, let's gauge everything by history and physical. Your history and your physical are going to give you almost everything you need the vast majority of the time. If you pay attention to risk factors, because the smaller ones, the younger ones, the ones with underlying conditions, the ones that were premature are definitely going to have a worse prognosis, going to need more time, more support. Be aware of those things in the diagnosis. But again, we've actually taken the trouble with, at a national level to review everything and make some very strong evidence-based recommendations that we be clinicians, that we be thoughtful clinicians, gauging things by history, by physical, aware of underlying risk factors, and then again, jump right into the testing that we often don't need. You do not routinely need an x-ray. You do not routinely need a lab. Are there some instances where they might be helpful? Absolutely. But routinely, if you've got a good clinical scenario for bronchiolitis, we're going to go with history and physical and clinical decision making. So that was on the diagnosis side. On the treatment side, again, we're not talking about older kids who've had recurrent illness. We're not talking about, again, pure bronchiolitis. If they come in with their first episode of a bronchiolitis-like illness, they're wheezing, they've got wheezes and crackles, they've had congestion for a couple days, and again, it's our most common illness, so you're going to see plenty of it, and I suspect a lot of us have a good feel for. But when it's bronchiolitis, there is very strong recommendation with high quality evidence that we avoid bronchodilators in all forms. Avoid albuterol, avoid epinephrine. For the most part, avoid hypertonic saline. And again, this is a high quality evidence with strong recommendation, because when you really look at the studies, we have ended up hurting too many kids with albuterol or epinephrine. You give a kid an unnecessary sympathomimetic or beta agonist drug, and they end up with tachycardia, they end up with some agitation, and then on occasion someone ends up chasing that with IV pokes and fluid boluses, and again, the more you do, the more possible complications you can have. So if you're dealing with pure bronchiolitis, it's a disease of mucus and edema in the airways. It's not a disease of bronchoconstriction. Their lungs are small and tiny and full of mucus and edema. Their lungs are not bigger and reactive and full of bronchospasm. So it doesn't matter how much bronchodilator you give to a little tiny airway full of mucus and fluid. It doesn't matter. You will end up hurting kids more often than helping them in a setting of bronchiolitis if you give them albuterol epinephrine. So really strong evidence there. In the category of hypertonic saline, mixed reviews, really difficult to sort these out. Every year or two another study comes out thinking that it's actually going to work this time or that it actually doesn't work this time. Really hard to evaluate the literature on hypertonic saline because so many people assumed that it was bronchospastic and gave it in combination with one of the bronchodilators. So it's a little bit more mixed, a little bit harder to sort through, and the official guideline is it doesn't help kids acutely. If they're sick enough to be hospitalized and you just feel the need to throw everything you can at them, you can consider it within the hospitalized setting. Certainly our ICU has on occasion given it a try to some patients to try to prevent escalation in their respiratory therapy. But again, routinely outpatient emergency department, avoid, avoid, avoid. Steroids is probably the most harmful thing that we can do for bronchiolitis. Some good studies showing harm from that. So again, we're not dealing with asthma, inflammation, and bronchospasm. Avoid steroids. And again, there's plenty of studies out there that suggest that all we do with pulse oximetry is drive ourselves crazy, drive parents crazy, and increase cost, increase length of stay, but have no impact on morbidity and mortality. Growing evidence. Every time someone does a study, we end up with, wow, pulse ox really doesn't help us very much. It really doesn't harm kids to have borderline low sats. Probably down to the mid-80s is what a lot of these kids are doing at home. And again, if the other clinical factors about their overall energy level and their feeds and their respiratory rate, the overall clinical factors that we can easily see on a history and physical predict that the child is safe to be home, we don't need the pulse ox. If the overall clinical factors, as we look at this child, predict that they need to come in, it doesn't even matter what their pulse ox is. Do we feel better because there's so many things we can't do to be able to put them on some therapy, to put them on some oxygen? Yes, we do feel better, but there's just not good evidence that it's really a big part of this. Certainly if they measure low, we're going to put them on oxygen and spend some time with kids, but most of the decision making should come from all of that clinical information and not from this test that often leads us astray, that often doesn't have a good correlation, that the child wiggled. It's not an easy test to extrapolate a lot of information, and it's not necessary to extrapolate a lot of information from pulse oximetry when all the other clinical indicators. Don't do chest physiotherapy and don't do antibiotics. Obviously, you've got a viral illness, but some good studies reviewing chest physiotherapy. Even though they're full of mucus and edema, it's a little tiny bit all throughout millions of little airways, so you're not going to beat it out of them. If they have some atelectasis and they're in the ICU and it's a different, it's not just bronchiolitis, there might be some role for those therapies. But again, in pure bronchiolitis, we don't need all of these things. We don't need most meds. Several medicines are harmful. We should not worry about pulse oximetry so much, and we should avoid antibiotics until there's a clear indication for them. There are some things we can do amongst all of these don'ts, and certainly the big one is maintaining hydration. Again, like we said before, NG hydration is great. The gut should work. We should be able to give it very gently without risk of aspiration, coughing and choking on PO feeds, and certainly IV is another route that's available to keep kids hydrated, but often not necessary. And then there isn't any studies to gauge the evidence. We just strongly agree that it's easy, self-evident. And then from diagnosis and treatment on to prevention, be really, really stingy with palivizumab, the monoclonal antibody directed against RSV. That's the monthly injection. when we changed the guideline, when the AAP changed the guidelines, making it even more rigid on, or strict on how preemie and how young and how much disease kids had to have to qualify for percentages, a lot of us worried that we were going to see in those 30 to 34-week infants that were no longer getting this palivizumab prophylaxis were going to end up sick and hospitalized. And anecdotally, we have not seen that. I was really worried about this when they changed the guidelines. There was a study coming out of Italy, I believe, that suggested that they did see an increase in that population above preemies above 29 weeks who were no longer getting this passive immunization. So, but for the time being, we're still being fairly stingy, fairly rigid criteria. I actually got one sitting on my desk this morning from the Managed Health Services reminding us that here's what makes kids qualify, and it all starts with 29 weeks, 0 days gestation. Other preventative things, obviously washing hands is good, educating families, removing further respiratory irritants from their environment is always good. We're pediatricians, so we have to take every opportunity we can to promote breastfeeding because there's only about 1,000 health benefits to child and mother. And then I can pause here. We can talk, I've got some examples. We've kind of covered a little bit of this in the case that we started with, but here are some in-between gray area cases that are fun for discussion. But I'm going to go ahead and open the phone for questions, comments, and anything else.
Okay. I'm going to unmute the phones here, so if you are listening and you do not have a question or you do not want to make a comment, if you would please just put your phone on mute so that we don't hear your background information.
The conference is now in talk mode.
Okay. Is anyone on the line ready to make a comment, or does anyone have a question about what we've covered so far? We've got a few minutes left, and is that somebody who had a question?
I have a question. My name's Tricia Lally. I'm a general peds. Can you hear me?
Yes, ma'am, we can. Go ahead.
So I'm thinking that your discussion about NG feeding relates more to an inpatient rather than an outpatient setting. Is that correct?
Yes. Yes.
Okay. Sure. Yeah, right. So hydration is going to be a major factor in that, all the pieces of the puzzle. And in that same vein, putting the oximetry piece into the bigger picture, how do your comments relate to an outpatient assessment? So say you have an infant with, trying to generalize this question. Say you have an infant that is not particularly tachypnic nor tachycardic and reasonably hydrated, but you have a reliable oximeter that is on the low end. How do you can you make a few comments about the use of oximetry on an outpatient basis?
Yeah, and I think yes. Thank you for reminding me that yes, I often speak from an inpatient point of view, but and I don't expect that we should be putting NGs in kids and sending them home from the ER and having them follow up with primary care with this wonderful gift of some tube that you now have to manage. But so NG hydration, if necessary, by definition, those kids are spending some time in the hospital. And then going back to pulse oximetry, I think everything that was said is very applicable to any outpatient setting that is diagnosing these kids. That a SAT of 86% doesn't bother me, doesn't hurt a child in the short term, and there's no evidence to suggest that it's an important enough piece of information that it should dictate the care of that child. If you've got a kid who's not too labored, not too tachypnic, doesn't have huge risk factors, you're seeing him on day 4 of illness where he should be at his worst, and he or she is able to maintain hydration through oral routes, I call that family tomorrow. I keep them in the outpatient world, you know, is my recommendation, because again, we spend so much time and energy chasing pulse ox numbers when we really should be treating that all of those other clinical indicators. So I think all of that information that the AAP was putting out there, yeah, don't even bother, you know.
Yeah, thank you. That helps. Thank you for speaking more about that.
Thank you.
And to back that up, and Dr. Whalen can correct me, I know Carilion Children's, the hospitalist, intensivist here take quite a few consult requests through that. So if you had a patient that you were concerned about, that you thought was either borderline or you wanted to run it by someone to make sure that you had another brain on the way to try to figure out what the best care would be for this kid. Now they don't see the patient. They're relying on your exam. They're relying on your history and physical and that kind of stuff. But they usually can help remind you about things like this, of what we typically admit and what we don't admit. So
thank you.
Yeah, absolutely.
Yeah, there's always somebody on call through the transfer center, and yes, we get questions like that. I had one last night. If there's enough clinical indicators, what would we do with this information? And again, just as another comment on oximetry, we have a very concerted effort, and now that we have monitorability in all of our rooms, we have a very concerted effort to try and get kids off continuous pulse ox, because we get so many false alarms, and we're going to be at risk of increased length of stay if we leave kids on. If we just check them intermittently and get, while the nurse is there, getting a good, true, accurate reading with vitals every 4 hours, we do better, and we get kids out of the hospital faster. And again, it would take an actual study to prove that is indeed safe. But that's an inpatient guideline. This information here that's on the screen is outpatient recommendation from the American Academy of Pediatrics. On the inpatient side, we're trying to use the pulse ox in a non-continuous fashion, at least on the floor, when kids are off of their continuous therapy or non-invasive ventilation. And obviously ICU is a different story.
Okay. Anyone else on the line have a question or want to make a comment? Okay. I'm going to flip Dr. Whalen's microphone back on, and he can finish up our presentation.
So there's a bunch of thoughts. There's some guidelines. Certainly there's never a hard and fast rule in medicine that fits every child in every situation, and certainly there are going to be some kids who, like the first one on this example, where he's not a pure bronchiolitis. He's a mix of chronic issues and may very well have some This 12-month-old case may very well need a trial of albuterol with some close observation for effectiveness. Same with the second child on this list. This child may have some reactiveness to his airway. The 6-week-old on day 2 of illness is just to remind us all, we still have to treat the child clinically, even though he might get worse. If he's doing okay at this moment in time, we don't have to admit someone because they might get worse. And then my last case there just discusses, like the very first case we started with, how much workup do we do for these kids with fever. And blood and urine, I think, is a fairly standard thing to do. We're getting more and more liberal with the workup with our new protocols of, routine blood, urine, spinal fluid only being done on febrile kids under the age of 7 days. We're not even doing it in the 1 to 3 week range. We're starting with blood and urine and risk factors before we proceed with an LP. So again, here's a bunch of thoughts. Here's a bunch of guidelines that empower you to be a clinician and to treat patients clinically and not have to rely on labs, not have to rely on x-rays, not have to rely on imperfect information like pulse oximetry, but to put it all together and be a clinician for your child, and know that these guidelines aren't going to fit everyone. There's going to be kids that have an interesting enough findings, they do get a chest x-ray. probably don't need repeat x-rays, but a single chest x-ray is certainly a very inexpensive, very low-cost thing when it is indicated. So thank you all for listening.
All right, I'm going to flip back over here. There's Dr. Whalen's references for the AAP publication. If anyone else has a question, I know we're about 6 minutes over now, and that's a lot of information to absorb in these little quick lunch and learns, but if you do have a question, you can always email us at outreach@carilianclinic.org, and we can continue this conversation. I can put you in touch with Dr. Whalen or one of our intensivists or neonatologists or people on our outpatient side as well if you have questions specific to those areas. This is your information about how you get CME credit. So everyone on the line now can to the calendar appointment that you got the link in, and there's a little section that says credit. You click on that. There's a little survey you fill out, and that comes automatically to us. All of this information gets sent to our CME tracker system, so you can go online and see how much credit you've had throughout, the entire time you've had an account with Carilion and been participating in Carilion events. You can go back and print those off and help with your yearly tracking of those credits. If you're listening to this as a recording on our YouTube channel, you can get 0.5 hours of Category 1 credit now. What you do is you go into the notes section of the video, so usually it says show me more. You click on that and you'll see the link that also says for CME credit. Click here, and it's basically the same survey as what you participate in when you're live, when you participate with us live. You can go to the carilianclinic.org/CME webpage, and you can get information about the CME tracker system and figure out how to sign up, and also do a little bit of question and answer if you have any problems or anything like that. They list out their contact information, and they're extremely helpful figuring out how to use various functions of the system. With that, if there's no more questions, we are going to go ahead and disconnect the phone lines now, and we appreciate you all joining us today. And happy Halloween. Thank you all very much.